It's Dr. Lindsey VanDyke, and we're going to talk about gestational diabetes. What is that, anyway? This is a form of diabetes that is actually caused by pregnancy. The placenta makes a protein called human placental lactogen, and it causes insulin resistance and high blood sugars in mom. We do typically expect gestational diabetes, or GDM, to resolve in the weeks following delivery of that placenta. How do we diagnose GDM? There are a number of ways to do it. And classically, in the second trimester, between 24 and 28 weeks, your OB-GYN will have you drink glucola, which is a syrupy orange concoction, and check your blood sugar 2 hours later. The cutoff at the moment for a diagnosis is a 2-hour post-glucola level of 153 or higher. Similarly, if women have a fasting blood sugar at any time that's greater than 92, or a 1-hour post-glucola at any time that is more than 180, this also counts for a diagnosis of gestational diabetes. Patients ask, well, I had high blood sugars early in pregnancy. Is that the same thing? And the answer is no. If you have any of the following lab results, it counts as a diagnosis of regular garden variety diabetes. And that would be a fasting glucose greater than 125, a random glucose greater than 200, or a hemoglobin A1C greater than 6.5. So if a patient has gestational diabetes, how does that matter for the pregnancy? The presence of diabetes, whether it's the quote-unquote usual kind or gestational, has significant impact on a pregnancy. It raises the risks to mother and baby and needs to be followed closely and carefully, so that both of them can have the healthiest, safest pregnancy possible. Things that we run into when blood sugar is uncontrolled are babies with large birth weight, especially large heads, which make delivery difficult or require C-sections, sometimes early labor and delivery before the baby's lungs are mature enough to breathe oxygen, low blood sugar in the baby after he or she is born, as well as a higher risk for the baby of developing diabetes later in life. Okay, so for patients who have gestational diabetes, how do we manage it? Absolutely number one thing is lifestyle. Lifestyle is the cornerstone of success, as it is for all kinds of diabetes. Exercise, weight management, nutritional changes, portion changes are so key. Carbohydrate restriction, that is reduction in breads, rices, pastas, other sugars, is the key to requiring less insulin in the body. There is a California program called Sweet Success, and they provide guidelines for eating and exercise. We list this later under the resources section. Our job as endocrinologists or OB-GYNs or primary doctors is to ensure that our patients have access to the correct nutritional counseling. So what kinds of goal blood sugars should patients be aiming for? No matter what they're doing, if it's lifestyle or insulin or other medications, their fasting blood sugar during pregnancy should be less than 95. 2 hours after any meal, that blood sugar should be less than 120. And maintaining a hemoglobin A1C between 6 and 6.5. These are all optimal goals, but these goals will be adjusted if low blood sugars are a consistent problem. After the first trimester is over, sometimes other medications like Metformin can be used to help reduce blood sugar. Previously, drugs like glyburide or its cousins were used during pregnancy. However, as of May of 2018, these medications are no longer recommended for the use in pregnancy. Officially, according to all these guidelines, insulin is the medical treatment for gestational diabetes. Once a patient makes it to the third trimester, it is recommended to use aspirin to help reduce the risk of preeclampsia, which has to do with excess blood pressures, protein in the urine, and so on, which can present itself as quite a complication later in pregnancy. And the biggest question I get from patients is, will gestational diabetes come back? And if you get pregnant again, the answer is usually yes. It also significantly raises the risk of developing quote-unquote regular diabetes over the next 2 to 3 years. So I cannot underscore enough that it's very important that blood sugars are optimal before ever attempting to conceive in order to minimize and eliminate risks to mother and baby. We talk about in other diabetes handouts, the importance of contraception before a patient is ready for pregnancy. There are lots of reliable options that are available to women now. And of course, if you're done having children, there's always permanent sterilization for yourself or your partner. Resources that you should use when you have questions about gestational diabetes include Sweet Success in a section on consumer education materials at cdappsweetsuccess.org. Always check the Mayo Clinic for reliable resources at mayoclinic.org. The American Diabetes Association provides an excellent primer, as well as the American College of OB-GYN. That's at diabetes.org and acog.org. The Centers for Disease Control always offer a whole lot of data about a lot of different conditions, and this is one of them, so you can check cdc.gov.